in a way, I've maybe lost a little passion, but
Yeah.
it's still there. My feeling about this job is that we always need to be at our best when people are at the worst.
There are a lot of challenges facing rural emergency services. The top is staffing, next is reimbursement or funding, and those two might swap positions based on who you talk to. Yes, emergency medical services can be traced back to the Civil War, where a system to care for and transport soldiers was needed and implemented, but EMS as we know it today was really started to be intentionally developed in the 1960s. In 1966, the National Academy of Sciences and National Research Council released a paper, Accidental Death and Disability, the Neglected Disease of Modern Society. This paper reported that in 1965, more Americans died from vehicle accidents than did in the Korean War. That was a death rate of 25.4 people per 100,000. And if you read this report in 1966, you would have learned that 70% of motor vehicle deaths occurred in rural areas with populations less than 2,500.
What's happening back in the late 60s is cars are getting bigger, they're getting faster, the highway system is starting to be built out, and we're seeing more traffic crashes.
Of course, those aren't the stats today. The death rate from vehicle accidents is 12.9 per 100,000 people, with roughly 39 to 43% happening in rural places, according to the National Safety Council's Injury Facts website. But if you go back to the 1960s, when the Accidental Death and Disability paper was written, and look at the types of vehicles that could transport people in the supine position, interestingly, it was hearses from the local funeral home.
This is what starts the development of EMS in rural communities. So it kind of gets built out on wherever there's a funeral home, there's an ambulance service.
And they were operated by volunteers who weren't trained much more than in first aid as a transportation service, getting people from an accident scene to the medical facility in town.
So as time goes on, as healthcare starts to evolve, we start to see regionalization of healthcare. We start to see specialties. So we start to care for trauma patients differently, heart attack patients differently, stroke patients differently.
And people learned that in many emergency situations, time is of the essence. People needed to be trained to start emergency interventions ASAP, which included as patients were being transported.
So while we're en route, we always make sure that we do some continuous monitoring. You okay, Lynn? Are you breathing okay? Good. Okay. Are you having any pain right now? Good. Good. Well, your heart looks good there. See that 101 on the top there? If I can get that down below 100, I'm going to be happy. But you see, I'm such a strikingly handsome man that I usually have this effect on ladies, and so their blood pressure usually goes up and their heart rate does too.
We look back into the 70s when we created this model of rural ambulance based on volunteers, people of the community who are giving their time to serve their neighbors. And now fast forward to 2022, nothing's the same in a rural community than it was in 1973.
Historically, I don't know if we've ever seen anything like the workforce shortages we're seeing today. Healthcare has been struggling with workforce shortages for years.
Kelly Asche from the Center for Rural Policy and Development said that they've been researching healthcare consolidations for a few years.
That research led us to think a lot more about the role rural EMS is going to play in the future. As services continue to consolidate into larger cities and fewer services are being offered in rural smaller clinics, this means people have to drive a lot further for those services.
A research letter published in the journal Academic Emergency Medicine by the University of Minnesota said that these closures and consolidations are especially stressful on rural EMS providers trying to get patients to the hospital or another facility as quickly as possible. So, in 2016, the Minnesota Department of Health sent out a survey trying to understand where and how rural emergency medical services might be better supported.
When they released their results, they kind of did it in one big aggregate. This is what's going on in rural Minnesota and rural EMS.
But Asche's team wanted to understand the nuance between these different communities.
trying to figure out, like, do responses change to questions based on what region they were in, based on the population they serve, based on whether they were consolidated with a hospital? Did those types of things make a difference?
Those types of things did make a difference, and Asche said state and federal level policies should reflect those differences.
And some of the main ones had to do with whether a agency was, we'll call it consolidated, or had a relationship with a hospital system. Typically, they felt like they were doing better financially. They typically were able to offer more services.
Both Asche and Jones agreed that one of the most important things that can be done in a rural EMS program is to hire a full-time manager, or at least a formally trained manager. The CRPD's research showed programs that had one felt more financially secure, were able to offer more services, and could also handle recruitment.
So if you think about, like, the importance of having a manager at an EMS agency who's really thinking cleverly, intelligently, and in the field of trying to recruit new volunteers, that's the stuff that needs to happen, because they are competing against all the other employers in the region that are trying to do the exact same thing.
The school here in Redwood Falls did a interactive school afternoon careers class where a whole bunch of organizations, companies actually brought their tools of the trade, so to speak, to the school.
Louis Lawaji is one of 4 managers for CentraCare EMS. He's based in Redwood Falls, population approximately 5,100 in southwest Minnesota. He also said that working within the CentraCare network is beneficial by sharing employees and ideas, because each CentraCare EMS isn't tied to a specific CentraCare hospital. Bradley Hansen is the Senior Director of CentraCare EMS.
But we have responsibility throughout all of central Minnesota, working with our CentraCare partners. So when you look at Redwood, about 2,200 calls a year that Redwood covers. If you go to Wilmer, 45 minutes away, they're a little over 4,000 calls a year. When we put all of our services together in a year, we're about 14,500 calls as a system.
Hansen explained that in the early 1980s, Minnesota created a primary service area system. An ambulance service gets licensed to a particular geographic location and then has to offer 24/7, 365 coverage to that area. Minnesota is divided into more than 250 different primary service areas, and this helps with efficient and safe response times.
Because run volumes are important for ambulance services, that sometimes created some difficult situations. So the primary service area law was enacted to help us determine who was best suited and closest to that call area in order to take that call.
Minnesota is actually looked at as like a leader in terms of setting up our EMS system. I don't think people realize, like, there are still places, particularly in the South, where there are no emergency ambulance districts. It's when you'll get ambulances like trying to get to someplace as quickly as possible because they're competing to try and get that patient so they can get the revenue. And that used to cause accidents because you would have ambulances just speeding across everywhere trying to get to the scene first.
But a smaller service, like the one in Franklin, which is 12 miles from Redwood Falls with approximately 500 people, can request help from CentraCare. So basically, CentraCare is trying to solve for an economies of scale challenge in a rural setting.
Rural areas just don't get the call volume that a more kind of metropolitan place might have. So if you're serving a less dense population, let's say you're serving, 100 square miles, but there aren't that many people in it, your overhead is pretty high because you still have to have that ambulance, you still have to have the volunteers, you still have to have the equipment and everything to serve thousands of people, but you're only serving, hundreds of people.
And decreasing populations in rural Minnesota doesn't mean less ambulance calls. We're a population increasing in age, which also means we're a population increasing in medical needs, including emergency services. And think about the makeup of communities in rural Minnesota. Many small towns speckled throughout the landscape. People may work 20, 30, 40 miles away from where they live, drying up the volunteer pool.
So we just don't have the population to help volunteer during the day. But we still have the elderly population living in our area that gets sick during the day, and it's hard to find staff be able to leave work to help those people in need.
So how can rural places get better at responding to calls? Take a look at Lake Region Healthcare's location in Elbow Lake, formerly known as Prairie Ridge Healthcare, where Eric Risbrut works as the ambulance director. Elbow Lake is a small town, population approximately 1,290 in west central Minnesota. Risbert said that they also do school outreach.
Another thing is we're pretty fortunate here that we have our own hospital, so we can utilize our own staff at getting them involved.
I am an EMT and an administrative assistant. So my first responsibility is to the ambulance. So if we have 911 calls, I pretty much drop everything and go do that. And my second role, or my fill-in role when we're not busy on the ambulance, is to be the administrative assistant to the CEO and the other administration staff. So it could be a 50-50 split over the year. It's a new role, literally just created, so we're still developing it and still finding out what that's gonna look like over the long term.
Because it was challenging to find people to volunteer, Risbert started recruiting internally. He recruited Clausen, and it's the same situation with Travis Nyreen, who is a dietary cafeteria manager.
There's 5 of us that are employed through the hospital that can get there. Yep, and there's some other people in town that have jobs as well that can. So between all of us, it's, that's the family that we have, the EMS family we have.
So when a call comes in and you're working, tell me what is that like?
When I'm here at the...
Yeah, when you're here, yep.
That's a tough one. So it does happen. I always respond if I can. Did they explain the call structure and how that goes out?
Risbert did explain. They use a conference call system, and every volunteer, EMT, paramedic gets called, and they figure out who is closest and who can respond.
Prior to that, they had to be within 6 minutes of Elbow Lake, so we only could recruit from the Elbow Lake area, or if they worked in Elbow Lake. And then you'd had to put them on a schedule, and that's donating a lot of time, 24 hours to be on call. Now they only have to volunteer when that call comes out. Now we can use our small towns like Herman, Barrett, Wendell, asking those people to volunteer instead of just the Elbow Lake people. So if we have a 911 call in Herman, which is 20 miles south of here, the phone rings, we have 3 or 4 people on the service there. They can say, hey, we'll meet you on the scene, we just need to get the ambulance down there. So one person from Elbow drives down there, and we have a responder on the scene of the incident right away. Mm-hmm. So it improves our response times, and it improves patient care.
Like many other issues on the surface, the rural EMS one seems almost too complex to solve, but it's not. There are people thinking creatively now about how our system could be better through different ways of staffing and recruitment, conducting surveys and writing reports on how to support people in rural EMS, and thinking about the future of the industry.
I think the community paramedic and community EMT, I think that's the future of our industry. Taking care of people at the right place at the right time. So if someone calls 911, if they're just sick and they have no other option, to have the ability to send a healthcare provider like a community paramedic to their home to evaluate them, and then to be able to utilize those folks to address those social determinants of health. It's much different when we as EMS providers, when we go into a patient's home and we get to experience and see the environment which they live in. We have a better understanding of what needs may not be met.
It's a 24-hour job, but I know what the community needs. I know that they need an ambulance. I look at everybody as I'm taking care of my family or my loved ones.
No one wants to see a day where there isn't someone to respond to a 911 call. Thinking about how to recruit differently, to fund differently, to care differently is the future of rural EMS.